Okay, so I will be speaking on adnexal torsion, which is a very important topic and very important in point of that we need to suspect and manage the patients quite emergently. So this is an emergency, and majority of patients with adnexal torsion, they present with the acute pelvic pain. But out of women with acute pelvic pain, only 2 to 3% would have a torsion, in fact. And what we know about torsion is that when we talk about adnexal torsion, we mean that the ovary and the tube is torted, but we can also have an isolated ovarian torsion or an isolated tube torsion. They exist as well. And they can occur at any age of woman, and also in both pregnant and non-pregnant women. So what do we know about the risk factors for the torsion? We know that the pregnancy is a risk factor for torsion, particularly in the first trimester. If the ovary is enlarged, in case of the adnexal masses, in case of the ovarian hyperstimulation, or in cases of polycystic ovaries. And also, the women that had previously an adnexal torsion are at a higher risk for recurrence, and particularly those that had a torsion of a normal ovary previously versus to abnormal ovary. So if we have an adnexal torsion with an adnexal mass, most commonly it's a benign pathology. It can be a dermoid cyst, serocyst, adenoma, or functional cyst. And we know also that if a woman has an endometriotic cyst, they're less prone to get torsion because of probably adhesions. If you look at the pregnancy, half of the women get torsion in first trimester, 30% in the second, and 10% in the third trimester. And if women have ovarian hyperstimulation during the undergoing assisted reproductive treatment, it's about 0.8 to 1% of women who would have the torsion. And there's also a predominance of the right side versus left side, which is probably because of there is less space on the left side because of the sigmoid colon. So when the woman would present to the emergency room, they usually have an acute, severe intermittent pain, which is a classical. But sometimes patients can come without any symptoms if they would have had symptoms before, or they might have a mild pain. Therefore, the patient history is crucial in these cases. So when we assess the patient in the emergency room, we shouldn't only concentrate on the current symptomatology and release the patient because she's asymptomatic right now. We have also to take patient history, which is crucial in the diagnosis of the adnexal torsion. Between 45 to 70% of women would complain of nausea and would have vomiting, particularly together during the pain attacks because of the vagal reflex.
Or they might have a mild pain.
Some patients have diarrhea, and later on the patients may have fever, they might be subfebrile, they may have reactive protein elevation and leukocytosis. It occurs in about 15% of women and usually a bit later, after the onset of the symptoms. There are no blood markers available, no CA125, no other markers that would help us to differentiate this condition from others. What is going on then during the torsion? During the torsion, there is a rotation of infundibulous pelvic ligament and also tubo-ovarian ligament around its vascular axis, compromising first the lymphatic and venous blood flow, and later the arterial flow. And when the arterial flow is compromised, we have a stasis and we have a hemorrhagic infarction, which leads to the necrosis, to the tissue necrosis. So what are the ultrasound signs of the adnexal torsion? Ultrasound signs of the adnexal torsion are enlarged adnexa, ovarian stromal edema, follicular ring sign, Whirlpool sign, free fluid in the pelvis, and a typical position of the adnexa. So here you see an image of the enlarged adnexa with the stromal edema. Here we have the sign of the follicular ring, which is the edematosis with enlarged capillaries, with the hemorrhages surrounding the theca layer of the follicle, according to histological analysis of these ovaries. Then we have a whirlpool sign, which I will be talking about more within short. Then we have a free fluid in the pelvis, and also the atypical position of the ovary with the lesion or doubt. We see here the uterus, and this is the anterior compartment with the urinary bladder wall. And we have a lesion, adnexal lesion, which is placed in front of the uterus, which is not a typical position when we are having uterus in the longitudinal view. Whirlpool sign was first described in malrotation of the midgut with the volvulus, and later on in scrotum torsion. In 2004, the sign was described also in ovarian torsion, and later on in isolated tubal torsion. We can see Whirlpool sign on grayscale and Doppler ultrasound, and what we see is a twisted vascular pedicle. It has been shown that adding Whirlpool sign to the preoperative assessment in women with suspected torsion improves the rate of true positive diagnosis confirmed at laparoscopy. So here we'll show you the case of the Whirlpool sign, first at the grayscale ultrasound image. What we see here is we see the uterus here, and then we see on the right side the lesion, cystic lesion, and we see a very nice Whirlpool sign, which has a twisted vascular pedicle. Here we have the same image using the power Doppler ultrasound. With the help of power Doppler ultrasound, follow the twisted vascular pedicle as well, with remaining flow in the vascular pedicle. So, how we would look at the laparoscopy? If we look at the twisted pedicle, we see the twisted pedicle also at the laparoscopy, with the ovary and the tube involved. When we add Doppler ultrasound to the diagnosis of the torsion, it is very important to know that the presence of Doppler signals of blood flow within the lesion does not exclude torsion. And the absence of Doppler signals in the lesion does not confirm torsion. It means that even in cases of torsion, we may still have blood circulation and get the Doppler signals. And also, if we don't see any Doppler signals, it might depend on other factors. There might be still blood flow or circulation in the lesion or the ovary, but maybe we are not able to detect it because of the technical part, because of the pulse repetition frequency we're using. So we have to check our settings. It's very important. But in cases of torsion, in 40 to 70% of cases, there is an absence of Doppler signals. And first is the venous flow, what is disappearing at ultrasound image. And therefore, the most common finding when we see the blood circulation in the lesion is arterial blood flow. It is also important to know that later on, we will see the absence or a minimal diastolic flow in the arterial blood flow. And we can also compare the sides. We can also compare the left and right side, and we would see the less Doppler signals in the torted side compared to the other side. So here I will show you the torted ovary with remaining arterial blood flow in the ovary, but no venous flow. and we look at the diastolic flow. There's still remaining diastolic flow in this lesion. Doppler can also help us to assess if the lesion or ovary is still viable or non-viable. It has been suggested that the absence of arterial and venous flow centrally in the lesion, or low velocity arterial flow below 5 centimeters per second in the region of an axial branch of the uterine artery or the main artery of ovarian artery, absence of the reversed diastolic arterial flow and no central venous flow, and no blood flow in the twisted vascular pedicle would be signs of the non-viability. While if we have a presence of the venous flow centrally, or we have a peripheral or central arterial flow remaining, it would be a sign of viability. But of course, there is an overlap in these, so we must keep it in mind. I will show you now some images of adnexal masses with torsion. Here we have a patient with a classical one-side intermittent pain. And here we see the lesion. We'll play both videos. Again, we see the lesion here. It's a huge dermoid cyst that has been torted. I think it's quite difficult to assess. It's quite difficult first to identify the dermoid cyst, but again, we have the symptomatology. We see the lesion and we examined. We might see some Whirlpool sign over there. And here again. Here is a case of the torted mucinous cyst, and here is a case of torted hemorrhagic cyst. At our hospital, for 2 years ago, we had a case of bilateral ovarian torsion in the patient. I borrowed these images from my dear colleague. So here we see the right ovary that has been torted and the left ovary that has been torted. It's a very rare condition, but it still exists. So it's important to keep in mind that sometimes the rare cases that encounter in our practice. Here we have a case of the old adnexal torsion that has been missed when the patient had symptoms. And here we see the multilocular cystic lesion with thickened septa within that are irregular, which is a sign of the old ovarian torsion. And here is another case of the old torsion that has been missed in the emergency situation. Again, we see the septa that are quite thick and that are quite irregular. As I mentioned, torsion can occur also during the pregnancy, particularly during first pregnancy. And here we have a functional cyst torted during the first trimester of pregnancy. We see that the cyst is quite far away while performing the transvaginal ultrasound. We see the pregnancy, and then we see the cyst on the top. So here it is important, again, to think about the settings, that we have to think about the depth of the image, and also think that Doppler might be not that very informal because of the distance between the transducer and the lesion. But again, it was symptomatic, typical symptomatology for the torsion, and the torsion has been confirmed after the surgery, and it was a functional cyst. Here we have a case of the hyperstimulated ovarian syndrome. We know that in case of ovarian hyperstimulation, we have quite rich vascularization in the ovaries. So I would recommend that we compare the sides left to the right, because we would probably be able to see quite a lot of vascularization in the ovary, in the overstimulated ovary, but the comparison of the sides and the difference in vascularization between the sides might help us. It is a case of a torted paraovarian cyst, where we see the normal ovary with small corpus luteum, and then we see the small cyst. It was not a large cyst, but quite thick wall of the cyst, and this was confirmed surgically, the benign paraovarian cyst. So when we talk about the ultrasound signs of the adnexal torsion, mainly there are small studies. And small studies showed that most common signs of the adnexal torsion were enlarged ovary, the stromal edema, and free fluid in pouch of Douglas. In this study, there were in total 47 patients. Others show that a Whipple sign could be found in from 88 to 100% of the women with surgically confirmed adnexal torsion. And follicular sign, if we look at the hyperechoic follicles, might be present in 80% of cases. I think the largest series that is published is a series of imaging and gynecological disease, which has been published in 2020. And this is a retrospective study where cases of surgically confirmed adnexal torsion have been collected from 8 centers. So there were in total 315 cases with a median age of 30 years, and majority of women were premenopausal. Women had acute or subacute pelvic pain, and 77% of them underwent laparoscopic surgery, and out of them, 47% were conservatively treated with the untwisting and without the excision of the lesion, if necessary. So what is interesting with that we look at the patient history. 5% of women had previous adnexal torsion in this series. 3.4% of women were ongoing artificial reproductive treatment of any type. 2.7% had a current hyperstimulation syndrome. 11% had polycystic ovarian syndrome. If we look at the symptoms, majority of them presented with acute or subacute pelvic pain. Some of them, 2, had chronic pelvic pain. And 8 patients had recurrent pelvic pain. It was more common on the right than on the left, which is in agreement with the literature. 4% of women had fever, and 60% had nausea or vomiting. So it's quite a common symptom in these women. What were the ultrasound findings? Median largest diameter of the twisted organ was 83 millimeters. They were quite large cysts, but also as small as 3 centimeters. In 69%, they could see the ovarian stromal edema with or without peripherally displaced antral follicles. Whirlpool sign was reported in 79%. Free fluid in pouch of Douglas in 71%. Absent of color Doppler signals in twisted organ in 44%. And follicular ring sign in 38%. And this was according to the ultrasound reports that have been collected retrospectively. And again, if we look at the organ involvement, we see that in 45%, there was only over involved. In 9%, only tube involved. So we know that isolated tube torsion, they do exist. Both ovarian and fallopian tube in 36%, and para-ovarian cyst in 4.5%. Then the experts reviewed the videos and again assessed the ultrasound signs, and they concluded that the most common signs that were present in this patient group were ovarian stromal edema with or without peripherally displaced antral follicles. That was seen in 79%. And Whirlpool signs they could identify in 90% of cases that could be reviewed. So now we know about the ultrasound signs of the ovarian torsion. We move shortly to the management. So when we have a woman that presents with the acute emergency pelvic pain, we know that laparoscopy, of course, is a method of choice to confirm the diagnosis and to treat the patient in case of the diagnosis has been confirmed. And we know that in premenopausal women, we can successfully treat women conservatively by untwisting the adnexa with or without the lesion removal in up to 80 to 100%. It is recommended that after the untwisting the ovary, we would use ultrasound in 4 to 6 weeks to reassure the preservation of the ovarian parenchyma. And during this checkup, it is recommended to assess the ovarian morphology, the ovarian size, the vascularization, and also the development of the follicles. And if we're dealing with the woman in postmenopause, salpingo-oophorectomy might be considered because of the age, because of the other risk, and so on, of course, in agreement with the patient. If we talk about the ovarian fixation, we don't know, we don't have the sufficient data, risk versus benefit of it, so it's still unclear and it's not routinely recommended. So to summarize, the typical ultrasound signs of adnexal torsion are enlarged adnexa, ovarian stromal edema, follicular ring sign, Whirlpool sign seen at grayscale and or Doppler ultrasound. And later we can also see the free fluid in the pelvis. And if you see any of these images, you probably recognize the case of the torsion. And if using Doppler, remember that if we see the Doppler signs, it does not exclude the torsion. And if we don't see any Doppler signals, or if we see in central venous, or if we don't see any blood flow in the twisted vascular pedicle, there are signs of the non-viability. And then we, even if the patient has mild symptoms, we have to keep in mind and to go on with the treatment of the patient. Thank you so much.